All right, guys. Well, thanks for coming on the show. I appreciate all your availability and everything. Everybody's so busy, has lots of things going on, so glad we were able to coordinate this. Let's just go around first, and you can just say your first name, kind of past experience, and then we'll kind of launch into some of the topics.
My name is John. I've been a paramedic for 22 years, and I've been a firefighter for 20 now.
Dang.
Jason, I've been doing EMS since 1998, however long ago that was. Became a paramedic back in '08, so I've been doing that for quite a bit now.
Nice. That's the year I think I got my EMT was 2008.
My name's Terry. I was EMS since 95 and then became paramedic in 97 and retired in 2017, and that's all I do now.
Nice.
Yeah.
I'm Kash. I got my EMT in 2007, and then I went to medical school in 2014 and completed my fellowship in 2022. Did an EMS fellowship that I finished in 23, and in 2023 became a paramedic. And now I serve as a deputy medical director for several local EMS agencies and work in one of the local hospital systems in various different emergency rooms.
Awesome. Well, thanks, guys. I wanted to start with kind of some medical director type topics because I feel like we've tried to get to these in the past and just haven't. So we wanted to talk first about kind of how to determine capacity, which is a word that no one really knows the true definition of. And that's one thing that you guys as medical directors tend to get the most phone calls about probably. Is like, do we need to force this patient to come into the ER? Or do they have the capacity to actually stay home? So Kash, if you want to kind of start talking about that a little bit.
Yeah, it's definitely not a, one of the cool, sexy, whatever topics, but it is unfortunately a significant reality of what we deal with, as I'm sure everyone in this room knows. And it is probably one of the top, I would say, top 5, if not top 3 areas of liability in EMS, right? You think about critical procedures like intubating someone or doing CPR or something like that. And then, documentation issues. And then number 3 would probably be the refusal.
Yeah.
And how we determine whether or not someone has that capacity to refuse. And this is, Aaron, this is a point you and I kind of went or discussed briefly, was the difference between capacity and competence or competency. So I'll pitch it to the room. What is that difference?
I mean, when I was in EMS, I think like we put a lot of stock in being AAO times 4, right? You can name where you are, the situation that's going on, who you are, your date of birth, that kind of stuff. But that's not really enough, I don't think. Like we would say a patient is or is not AAO times 4. And I think I would use that mistakenly a lot as competency. But even my understanding now, I feel like I have to refresh every 6 months as to what that actually means. But yeah, what are you guys' thoughts?
I think it's understanding either their illness or injury and the potential consequences of not seeking care.
Absolutely, yeah.
And I think if they understand that, to me, they can refuse.
Mm-hmm. Yeah, I think that's a good definition, I think.
The big difference is capacity is very situational and very specific and can be determined in a medical setting. Usually has to be a physician that makes the definitive determination. But when there are set guidelines in place, then a physician surrogate, i.e. PA, NP, if you're not in a free practice state, but if you are in a free practice state, then that PA or NP can make that determination. And then out-of-hospital clinicians, so EMTs, paramedics, with those specific guidelines, can make that determination. But again, it's very case by case, right? Competence, in the true classic sense of the word, is a legally determined status. So it has to be determined in a court of law. So that's why we don't determine whether someone is competent or not. We determine whether they have the capacity in a particular situation to make a decision for themselves.
So it's really more simplistic than competency, which would have to be determined by a judge.
Correct.
We're just making sure they understand the current scenario. Can you think of any recent phone calls you've gotten that apply to that?
Sure. So, one of the recent phone calls that I got started, I should say, the very way that you just described, with, hey, so I wanted to call you about this patient who, the initial call was for XYZ. I'll get into the sort of specifics in just a moment, but after they told me a brief intro to the situation, and the patient's alert-oriented times 4 GCS 15 common cooperative, and then it stopped there. And in my head, I'm going, and like, what have they told you about what's going on? What have they told you? It's just exactly as you said, John. Do they understand the risks, the ramifications? Do they understand what's actually going on around them? And so this particular patient was even on the more dicey side of the spectrum of capacity, because there was a potential mental health component to it. They hadn't contacted EMS. They were in contact with their therapist, and there was something was communicated to that therapist, who became concerned, reached out to local EMS, who then presented to the scene. And the patient never wanted to go to the hospital. They were looking for additional resources. What can I do about my current mental health? And was very clear, like, I'm not going to the hospital. Okay, why aren't you going? And when I delved into it a little bit, okay, why aren't you going to the hospital? I don't have that kind of money. That's a rational thought there, right? Mm-hmm. Which leads me into some of the specific components of capacity. So in order to determine whether someone has capacity, you have to fulfill basically 4 things, right? Patient has to communicate a choice. In this case, I don't want to go to the hospital. That's their choice, right? Or the choice they're trying to communicate. Or in another setting, I don't want you to give me this medication. I don't want you to do this surgery. I don't want, so on and so forth. Communication of a clear choice. The second piece of it is an understanding of the current situation, right? What led to why we're here. And these are questions that I should back up a little bit. These are questions that should realistically be asked in an open-ended fashion. So, for instance, Jason, if I were to ask you, do you feel well enough to stay home? That would be more of a yes or no question, right?
Right.
And so I'll play the patient in this situation. Go ahead and ask me some questions to see if I have capacity.
Okay. How are you feeling today?
I'm fine. I don't know why you guys are here.
Okay. Any pain? Any problems anywhere?
Nope, I don't hurt.
Okay. Any idea why we would have been involved?
I honestly, I don't know. Someone called you, but it wasn't me.
Okay. Just trying to figure out some recent events, why we might have been called. We sounds like we got a call from somebody outside. You might have explained some communication, looking for resources. We're just trying to get to the bottom of some of that.
Oh, was it my therapist that called? Is that what happened here?
Possibly. We don't really have that kind of information.
I told this is a complete violation of my trust. Like, I trusted them with this information. I told them not to call you guys, and here you are. Like, this is not okay.
Yeah, that sounds very frustrating. I can feel your frustration there. Well, we're here. Let's just try to get to the bottom of what's going on. So some of the silly questions we have to ask. We have to ask in some of these. We ask these to all patients, right? So what day of the week is it?
It's Wednesday.
Okay. You know what city you're in right now?
Yes, I do. It's XYZ City.
Okay. I see you have a friend here. What's their name?
That's Andrew.
Okay, great. So have you made any threats against yourself? Have you made any comments or tried to hurt yourself in any way?
No. I mean, I might have said that I don't, that everything's burning up around me and I don't see how we're going to move forward and the world's going to end, but I don't want to hurt myself. I don't want to be hurt, but the world's going to end. Like, you get that, right?
Okay, but you haven't made any threats to yourself directly or anything like that?
I mean, not recently.
Okay. Have you ever attempted to hurt yourself in the past or made threats against yourself in the past?
I mean, yeah, previously.
Okay. And then we would dig into a little bit of medications and medical history and all that, but it's a conversation.
Right.
Trying to get to the bottom of things.
Exactly. And so what I was hoping would be apparent out of the interaction that Jason and I just had is that this is someone who's able to understand their current circumstances, right? They understand that EMS was contacted. They don't know why. And they, upon connecting dots in their own mind, realized, oh, this is probably what happened, and expressed frustration with that situation. So an understanding of the situation would realistically be, can you tell us how we got here? Kind of exactly what you asked. What are the circumstances that led to the position that we're in? Do you understand the illness that you're currently experiencing, if it's a medical thing, right? And then the third piece of it is understanding the risks and benefits of either accepting or refusing care, right? Because capacity goes both ways. It's not only just refusing, but it's also informed consent about what we're about to do to someone, right? Because as healthcare clinicians, we are effectively legally allowed to do things to people that if anyone else were to do it would be assault, right? Would be battery. And so an understanding of those risks and benefits of, not just, do you understand the risks of refusing care? Yes. It's not a yes or no question. Can you repeat back to me in your own words what our concerns are about your current condition? Can you repeat back to me in your own words what the risks are of you refusing care? What could happen to you? And then the final piece of it is that clear communication of their final manipulation of that of that information. So
now, if they're overtly suicidal, what role does that play? Because I know that's something that's changed a lot even since I've gotten out of EMS, I think, especially with the culture of the police department not doing what they used to do, back when I first started, and they would help us force suicidal patients to go to the ER, and now they're very hands-off. They won't make entry into patients' houses. I guess what's the culture currently as far as our ability to make entrance into a patient's house, and what role does suicidality play in the competency?
That's a great question. So the general teaching is that anyone who expresses overt suicidal ideation does not have capacity to refuse care for the assessment of that particular aspect. They cannot refuse further mental health evaluation. They can say, don't put an IV in my arm. They can say, don't give me this medicine. They're allowed to make those decisions because, again, capacity is specific. So what they are not allowed to refuse is evaluation by a trained mental health professional to determine whether or not they are truly suicidal and whether or not they truly need further mental health care. So, to answer your question, if we have reasonable suspicion that a patient, because at this point we've completely separate discussion, but we've determined that there is a patient. If we have a reasonable suspicion that that patient is a potential danger to themselves, then we have an obligation to assess that and make sure that if it is not the case, then it has at least been fully explored and that person has been deemed safe to continue about, the rest of their typical activities, or if they truly are a danger to themselves and require further care.
And I would imagine we're not making entry into patients' homes anymore like we used to. We're not breaking down their door for reports of suicide, right?
Yeah, it's changed a little bit where if PD isn't willing to play along and do some of those things, then we're like, well, the scene isn't safe. Our safety comes first. That's kind of the direction we've gone. But it should be added here that we now have a resource in our particular situation. We have a CRT team, crisis response team, and it's a police officer for safety, a paramedic, and a trained counselor that comes out and they're a true mental health professional. They come to the patient, sometimes unbeknownst to the patient, and this is truly their area of expertise. This is the area that they thrive in, that they shine in, is suicidal ideation, trying to get to the bottom of that. So the problem is that's not always an available resource, and now we're back to kind of this kind of discussion.
Right.
So,
And so it's kind of, the rule is like, if our safety is going to be compromised, we're going to leave this patient. But if we can talk them into going, then, ethically, morally, we're doing the right thing. But we're also not going to compromise safety to kind of do what we used to do back in the day and 4-point restraint people and force them to go in against their will. And, yeah.
yeah, exactly.
Yeah. Yeah, that was why at the beginning of my career I felt very unsafe, especially working nights. We were in those scenarios so often where we're like, this patient's saying they're suicidal. There may or may not be the police department on scene. And we're like, all right, well, I guess this is our obligation, is to tackle you to the ground and force you to go to the hospital. And that's probably not doing people a lot of good either. But
Potentially leads to escalation of the situation, especially if there's other underlying mental health disorders. And
that's been those cases, I think, that made the police department change their policies, is they escalated things that didn't need to be escalated, and somebody was harmed as a result. And we learned maybe we don't need to, if they're not doing a criminal activity, we don't need to force our way into their house. They're not threatening anyone else.
I have an ER question.
Yeah.
With these guys, not me anymore, but these guys, if they do call you and you put a patient on a hold and they bring him into the hospital, is that your patient? Or can any other doctor in the ER see that patient?
Anyone can see that patient.
So even though you put him on a hold, any other...
So realistically, we don't put patients on holds that we haven't seen. The way that, at least in our state, the way that it works, and this is the way that it obviously every state is different. Every local jurisdiction's protocols, policies, so on and so forth, are variable. But the way that it works for us is, at least now, we have the ability to put someone on a transport hold. And that can be initiated by EMS. And so EMS has a reasonable suspicion that a person is a threat to themselves, a threat to others. They can initiate this transport hold. They can hold the patient specifically for the purpose of taking them from where they are to the emergency department. Once they're in the emergency department, they get placed on, at least for us, we refer to it as, it's effectively a temporary hold to facilitate mental health assessment, right? They are on a hold until we determine that either there is no reason for them to be on a hold, or that, yes, there is a reason, and now it becomes a formal mental health hold.
So it's not truly that 72-hour M1 hold, at that point. And we rely heavily on our mental health evaluators to really make that determination, because they have the time to go spend an hour with the patient, call their immediate family members to get collateral information, a lot of stuff that we just don't have the time to do. So we do rely on them pretty heavily to make those decisions.
Absolutely.
With the caveat, if we're worried and they come back not being worried, we will disagree with them on occasion. But they have the time and ability to look at more historical records and past mental health evaluations and things like that I think help a lot.
And I would say that it's very, very rare that we would disagree with their assessment of the patient. We tend to defer to their expertise, even in situations that are kind of gray areas, because usually if it's someone, for instance, that myself or Aaron would say, this person needs to be on a hold, the evaluator will come back to us and they will say, yeah, this person's going on a hold, and there's nothing unexpected about it. I would say, and Aaron, feel free to correct me if my perception on this is wrong, but it's quite rare for the evaluator to come to us and say, no, this person doesn't need to be on a hold, and we completely disagree with that.
Yeah, I would say that happens maybe once or twice a year where I'm like, well, this person had grabbed a gun, they have access to firearms, I understand you've talked to them and they're not saying they're suicidal now, but when I initially saw them, they talked about grabbing a gun and had access to it. And then in those cases, I will err on the side of caution and say, let's just keep them on a hold. With the understanding that, it's not like putting someone on a hold is the solution to all of their problems.
Right.
They do find that, I think, hospitalizing these patients inpatient for psychiatric reasons doesn't necessarily cure them of this and maybe doesn't do much benefit. And mental health evaluators are good about seeing that too. They can look and see, we put this patient on a hold X amount of times and it's obviously not helping. I don't think inpatient's going to benefit them. And that's true too, but we're also trying to mitigate our own liability, for high risk patients. So it's a balancing act for sure. But yeah, it's very, very rare that we would disagree with the mental health evaluators. But it's usually scenarios like that where we saw somebody that was completely different maybe when they came in than they are 12 hours later now that they're sober or now that they're coming off of meth or whatever it might be.
Exactly. The the phenomenon of drunkicidal is a very real thing, or methicidal. These substances that induce altered mental status can do so in many different ways, and that's the other important piece of capacity is if there's any suspicion that their decision is being influenced by either a substance or internal stimuli, hallucinations of any kind, then that is definitely something to be concerned about, right? Mm-hmm. And especially the ones that are really tough are the ones that involve patients that are responding to auditory hallucinations, command hallucinations, because those patients might not be forthcoming about that, right? And the big thing is when they're doing that manipulation of information for you because of your process of determining their capacity, changes in their understanding of the situation or their decision, vacillating back and forth, can clue you into maybe this person doesn't actually understand what's going on here.
How do you guys kind of document the safety things when you decide we are leaving this patient on scene? Like what kind of stuff are you guys documenting to kind of cover yourselves of to justify we do not think this is a safe situation, we're going to allow them to stay on scene? Are there particular things that you guys are seeing?
Do you want to answer that?
Go ahead.
Okay.
I would answer it more from the officer standpoint of going to the paramedic.
Yeah. I think as much information as you can put to give yourself more evidence, the better, right? To where anybody that reads that report has the story and can go, okay, it sounds like this patient was able to make their own medical decisions. Sounds like they were of sound mind. Sounds like they didn't have a plan. There weren't threats. This is the situation. So it's not just like one simple thing. This is where our documentation really comes into play, where we're expanding things out even more to help cover ourselves. And that's how I always think of it, as like, am I going to hear about this later?
Right.
I don't want to hear about this later.
Well, and in the case of somebody that's like, yeah, I'm suicidal, I'm not going to go with you guys, I'm going to fight you guys, their body language speaks that they're going to be very aggressive. How do you guys handle those?
Just documenting all of that, right?
Yeah.
We're not gonna put words in their mouth or say patients seemed like they were crazy, right? We're gonna explain this is what the patient was talking about, and then somebody reading that goes, sounds like they're crazy, right?
Yeah.
It sounds like you guys made the right decision. So a lot of it is just kind of painting that picture, and then that way there's really no doubt there.
Right. Okay.
It's tricky to do.
Yeah, 100%.
We would also call for the police department. So if someone's starting to get aggressive, the officer is usually going to call for PD. We're going to back out. So someone's going to make contact with that person. So now if they're in custody, we can re-engage with the person. Or if PD is like, we're not going to do anything, that's what I would document as an officer.
So for example, I guess you call Kash and he's like, yeah, this person doesn't have decision-making capacity. I think they need to come in. They're on a transport hold. And you're like, well, we're not going to tackle this person. You kind of back out, get the law enforcement involved, and then kind of go from there, kind of a thing.
Correct. And hopefully they would be on scene already,
Sure.
and so they would hear about it. Because they can go down there, the legal route of getting, I think it's an M1.
Yeah, because officers will write M1s, which our mental health evaluators may or may not agree with. So there's, even the officers writing an M1 hold does not mean the patient's now being held for 72 hours, because often their understanding of what an M1 hold is different than what it is in reality. We'll see it occasionally, the very intoxicated patient they'll put on an M1 hold and say they, usually it goes down the line of gravely disabled. which isn't really gravely disabled. When they're sober, they're going to be able to care for themselves, and we're not going to keep them for a full 72 hours kind of a thing.
Exactly.
So we do see that, but it's also a newer thing for the police department too. They haven't been writing M1 holds that long, so I think they're trying to do the right thing for somebody, and their understanding of an M1 isn't necessarily the same as our mental health evaluators. But
I think it's more of that transport hold of
yeah.
let's just get them.
And it probably does cover them. They're like, I wrote an M1 hold for this patient, so now I can legally put them in my car and take them to the ER, whatever it is. That's
And
true.
for anyone listening that is not within our state, there's different names for the hold in different states. California calls it a 5150, and there's different levels of there's different states with different levels of what EMS can initiate, what law enforcement can initiate, and excuse me, there are some states where even a physician cannot initiate a mental health hold. It has to be a petition to a judge. And so it's very variable, and every jurisdiction is going to have its own nuances as to how that gets navigated. The complicating factor now is the law enforcement piece, given the climate that we find ourselves in over the past 5 to 7 years with a lot of these high profile cases that have occurred. And so I think one of the challenges, at least as far as the EMS aspect of it goes, is ensuring that cooperation between law enforcement and EMS of look, we're concerned about this patient's safety, and we're concerned that not only could they potentially harm themselves, but if we try to render care or facilitate transport, they could potentially harm us. And identifying where that line is, because there are some states that will say, we're not going to touch this person unless they have harmed someone. And I've been involved in discussions previously of, so wait, one of my clinicians has to get assaulted before you're going to do anything? Even if this person is posturing, even if this person has already injured someone else that's not involved currently, you're not going to do anything unless they attempt to lay hands, or in some cases have already laid hands. So making sure that is a very clear discussion that is had prior to finding ourselves in any of these situations is very important.
Yeah, that's a good point.
It's good too to, when in doubt, get med control involved, right? Then it's not just you hanging out on a limb making these decisions that you're like, okay, am I going to end up in court over this? Go up the chain and get some backing.
Yeah, especially now in today's environment, like that's a very real possibility, where when I was a paramedic, it really wasn't much of a possibility, but now, there's been a lot of cases where you get, prosecuted for it. So it's definitely, you don't want to carry the coffin alone, is what we say when we're debating consulting a specialist or whatever it is. The answer is usually like, just talk with the specialist so that you're not dealing with this liability on your own. You've involved every party that could potentially help you. And yeah, that's a good fundamental. So I would say, like, if you're debating calling medical control, probably just do it. If you're debating it, just because it's obviously a scenario you need some extra backing, for your own liability and protection too.
Absolutely.
And from the medical director's standpoint, we would much rather have that call during the course of the case to help provide guidance, rather than having to put out fires afterwards. It's much easier to address a situation as it's happening, rather than trying to mitigate the after effects, so to speak, right? It's a lot easier to create a defensible situation rather than discuss whether a situation was defensible.
Which
Well,
I think go ahead, Jerry.
It's gotten easier, for you guys, with the cell phones, because back in the day it was all on radio, and it was really difficult, trying to carry on a conversation on radio.
Absolutely.
Click, wait, click, and now you can carry on a conversation with you, tell you, and you can interact. You can ask questions right back and forth. So that's helped out a lot.
And we have the ability to video
Right.
converse
Oh, wow.
too. So now,
They
it's
can
like
see.
it's like teledoc for EMS form, where we can now do that over the cell phone. So it's
that's
a lot
super
better
So
than
you
it used to be.
can actually see the rumble going on.
Right.
Yeah,
Correct.
Look at this guy. What do you think, Doc?
yeah.
Because we used to do that a lot. I mean, it was like one of the most liberating things was that I learned years ago was to call the hospital. And once that hold was put on, it's like, okay, you're done. You're going to the hospital. And then you made sure there was usually 6, 4, and 2, and then a couple cops. And I won't lie, it was fun sometimes.
Yeah.
It was,
The
let's
easy
go.
way or the
Yeah,
hard
just say
way.
you're
Yep.
going to go easy or hard, and
Yep.
I'd rather you go easy, and then the next thing you know.
The other really nice implementation we've had in our system is our physician advisors. It's not just some random ER doc that has no clue what our scope is, what our guidelines are, that sort of thing. It's one of our physician advisors that is familiar, and they're always on call. So we can call them any time of the day or night.
Yeah, when I first started in the ER, it was still the radio thing, and they're going to hand it to the nearest ER doctor. And, like I work with all of them. I know, we get new grad ER doctors, and they have no idea what you guys are doing in the field. They have no idea what you're asking, really. And so their answer is always like, well, bring them in. And they're like, well, you haven't heard all the details. Like, you need to actually listen to this explanation. So it is super helpful to know somebody that knows your protocols, because most of them don't, and a lot of them have no experience with EMS at all other than getting report when they bring in patients. So, yeah, I think that's really important. And there's so many of you guys now. It's not like the burden's all on one of you to take that phone call. So that's helpful.
And it goes beyond, well, just bring them in. Because sometimes that's not what the call is about, right? Sometimes the call is about, I know we need to bring this person in, but we're looking for guidance for how.
Yeah.
That's what's complicated right now. Like, where do we go from here? What do we do to facilitate that? And that's the reason that we have the system set up the way that we do. And there's good data that has been published that EMS calls go better when... Let me back up a moment. EMS calls involving calls to medical direction go better when the medical direction is given by an EMS board certified or fellowship trained physician.
Absolutely. Yeah.
Because of the fact that we understand that system. Even if it's not the same system, right? Let's say I find myself in, I don't know, let's say I find myself in Iowa. And for whatever reason, I'm doing a locums job, and their system is set up that whichever doc is in the ER takes the call, and that's the way that it goes. And I happen to get that consult call. I'm going to be able to understand, okay, these are protocols that I'm not familiar with, but theoretically the crew on the other end of the line should be familiar with. So I can ask those questions of, okay, this is the condition that we're dealing with. What pharmacologic agents do you have at your disposal that would potentially work? What are your guidelines currently saying for this? And then do you have these other things available that would allow us to potentially deviate? As opposed to, all right, well, give them this medication. Doc, we don't have that medication. All right, well, then do this procedure. Yeah, we're not allowed to do that procedure.
Yeah.
Right? Those are the kinds of complex situations that a physician that's not necessarily as familiar with EMS might create for the crew on scene, whether or not it's because they're indifferent to EMS or whatever. I'm speculating, of course, on a hypothetical situation, but there are those physicians out there that sure, I'll go ahead and say it, that don't care about EMS. It's just one more burden that they have to deal with while they're on shift. And the shift to board certified emergency medical services subspecialty trained physicians has resulted in better overall care of the patient in the out of hospital setting.